The following podcast is part of a certified educational activity titled Off the Shelf and in the Clinic for NHL, leveraging biospecific antibody strategies in DLBCL, FL, and beyond. Access the entire activity and complete the post-test at peerview.com/YAZ860. Downloadable slides and practice aids are also available.
Thank you for attending our meeting. It is going to be an educational event talking about bispecs with the title Off the Shelf and into the Clinic for NHL, leveraging bispecific antibody strategies for aggressive lymphomas, follicular lymphomas, and beyond. I would like to welcome also my two co-speakers, Dr. Gabal and Dr. Jay Gaddett, who joined me. Then there is, of course, very important, the HealthTree Cure Hub that really has halved the new way of how to directing things to us. And their major focus is education with several activities spanning from our news articles to policy and advocacy groups for all patients that are in dire straits. So let's go to the goals for today. During this presentation, we will learn the evidence continuing to support the ongoing integration of CD20, CD3 bispecs across treatment settings, how to use bispecifics delivered as monotherapy and as part of novel combinations in aggressive and follicular lymphomas, including for patients with high-risk disease, treatment refractoriness, or CAR-T-exposed diseases. We would pay attention to the dosing and safety considerations that can show a success of treatment with bispecs. And newer bispecs targeting CD19 may offer alternative options for patients with relapsed refractory non-Hodgkin's lymphoma. Okay, let's move on to the principles. Key understanding of bispecifics, how do they work? It is actually not the first bispec that is being used in clinical practice, but it is now based on the IgG full-length antibodies containing CD20, majority of them, and CD3 as a pan-T cell marker. It's an off-the-shelf availability. It targets the epitope of CD20, potentially also for co-administration of other CD20 antibodies. The Fc mutation on all bispecs is there to avoid killing of anti-tumor T cells. It preserves binding for prolonged half-life, shares the PK data for, generally speaking, other monoclonal antibodies. And as you most probably are aware of, CD20 is not the only target that we are looking at, but also CD19, and we will discuss that on the road. What is the regulated status of CD20, CD3 bispecs in aggressive and follicular lymphoma? We sort of felt that we discussed four of them with mosunetuzumab, Epcor, glofitamab, and Odro. Dextamab, the status is for majority of them are licensed in third line for both FL and aggressive lymphomas. And also, some of them are also licensed in second line, particularly in FL for follicular lymphoma based on the Epcor data, and also for glofitamab, GemOx in the European space for aggressive lymphoma in first relapse. Odronextamab currently is approved in Europe for aggressive lymphomas and follicular lymphomas. The interesting is that the CD20 to CD3 format is generally speaking 1-to-1, except for glofitamab, where we have a 2-to-1 format. So CD20 is exposed, is on the cell surface of glofitamab twice binding sites, whereas the others just have it once. So, and the CD19, CD3 bispecs are being actively tested in aggressive lymphoma, for example, survatamab and MG1045. So to go to a flow chart, how do we apply bispecs with the goal of being an outpatient of delivery? We can most probably reach more patients by using bispecific antibodies. The principle that we use, that we screen the patient for their patient observability by taking medical history and the geographic proximity, and of course also their ability to self-monitor what's happening. The patient education, I think, is really important in this context because it really will help us to capture the toxicities early onwards if the patient's educated, monitor protocols where the vital signs are frequently monitored just to catch early signs of cytokine release syndrome and to a lesser extent of the neurotoxicity. On the other hand, we as physicians also have to really have making sure that the patient is getting pre-medication appropriately. That's very important that that is really given to the patient, also in the outpatient setting. Really also educate the patient, remote patient monitoring, and obviously if they have toxicity and we treat the patient in the outpatient, have access to the emergency care for the patient 24/7, as this is quite important to really keep the patient outpatient if possible. So there remains a lot of goals for us to really use Bispecific. This is just a couple of examples, not of course all examples, but just a couple of cohorts of patients where I think Bispecifics really play an important role. That is potentially in patients who have received CAR T cells in curative attention. And the clear data set demonstrating that patients which are refractory to CAR T cells are in dire straits and do desperately need another option. Whereas for patients who actually are day 90 plus, potentially have a greater outlook if they are treated with another line down the road. Another group that we can identify easily is patients which are POD24 in follicular lymphoma. Those patients with progressive disease have clearly a much more inferior outcome compared to patients with not relapsing within 24 months. And to highlight the importance of this situation, if a patient is just relapsing after first-line therapy, in comparison to a patient with third-line therapy in follicular lymphoma, the overall survival drops dramatically in these patients. So these are just, for example, 3 groups where bispecific antibody constructs, they play an important role. With that said, I would like to move on to the topic rising to the challenges in aggressive lymphomas, sequential care with bispecific antibodies. With that, we would like to start out with a case, and this is Thomas, aged 80 years old, with a stage 4 aggressive lymphoma, with a mild congestive heart failure. Treatment history is one line of R-mini-CHOP, who had a partial response and progressed within 12 months. So I would like to discuss with my peers, what is the sequential treatment with these CAR T cells in the optional step? Could you consider earlier use of a bispecific if CAR T cells was an option? With either options, what are the differences in EU and US practice? I would like to pick your brains.
Thank you for the question. I think for the heart failure, it depends on how well controlled that is. Because patients who are compensated heart failure, you could still do a CAR T cell therapy, especially liso-cel, because it has less toxicity profile in terms of CRS and ICANS. You could still safely do a CAR T cell therapy. The question about would you consider earlier use of a bispecific definitely depends on, so that's a conversation about talking to the patient. Are they able to come to the CAR T center? Are they able to get admitted? Do they have a caregiver? Those are all the questions that we may have to address before choosing between bispecifics and CAR T. I think about the practice, I don't know how different it is. Here, if it is the approval is for anybody who has relapsed within the first 1 year or has not received like early relapses. Other ones we are offering CAR T in the second line treatment. I don't know, Dr. Capella, what your thoughts are?
No, I agree. So for a patient like this, we would definitely consider them for CAR T. Obviously, there is going to be some regional differences. So, depending on how much risk you want to take with a heart failure, you would, in a situation like this, you would want to work with your cardiologists in-house and get an opinion from them. Are they compensated heart failure? Is there is it excessively risky? Are they decompensated? But I think overall, for a patient like this, they could probably get to CAR-T. We would probably prioritize something like Breyanzi rather than Axicel to help minimize the CR risks. But then there's other factors too. So maybe they have other comorbidities. Maybe the patient lives far away. They don't want to commit to CAR T cell therapy. Maybe there's insurance issues. So not all patients who are eligible for CAR T eventually will get it. And in those situations, these are the situations where you would want to use a bispecific. So for a patient like this, I think they would be a good candidate for something like a mosunetuzumab polatuzumab combination if they're now going to proceed to CAR T. There's a question here about differences in the U.S. and the EU. So the glofitamab GemOx was the data was not approved by the FDA, but it is on the NCCN, and we routinely use it as well. I probably would not use glofitamab in this particular patient with GemOx. Maybe a non-chemotherapy approach with mosunetuzumab might be my pick in this situation. And there's obviously other options. You could do epcoritamab with GemOx. That's also another option.
Well, thank you for those insights. And we then went on to treat this patient with liso-cel in the second line, and he then progressed within 1 year after infusion. So what is the next steps in these patients?
So I think in this case, definitely a bispecific would be the best option if the patient is eligible and is able to get treatment. There are bispecifics approved in third line. Which one to choose? I think that is something. It's usually I talk to the patients about the data that we have in the approved agents, a time limited versus indefinite treatment. So I think that's something some patients may prefer to have, that like a limited treatment. Some may prefer to have like indefinite treatment. So usually I just present them the data and have a conversation with them, and then we make an informed decision. How to prepare for the unique step-up dosing and therapeutic dosing consideration. So definitely this is an 80-year-old male with a heart failure. So depends on how well the performance status is. You want to take into consideration about, do you want to do outpatient treatment versus something. Most of these, like for step-up dosing, that when we do admit them to prevent the monitor for CRS for 24 hours. So I think those are the considerations. You want to talk to the patient, see if that is something doable for them and it's feasible.
Yeah, no, thank you. I completely agree. Obviously, this is a high risk situation. Post CAR T failures is a high risk situations, but not all of them are the same. So if you're progressing at say 30 days, it's very different than say you're progressing at a year out. Obviously, if you're progressing earlier or not responding at all, that's much worse prognosis than a later relapse. But in a patient like this, yeah, we would recommend a bispecific antibody. I think one of the things to look for is, are they still expressing, CD20? Because most of the approved bispecifics right now are CD20 bispecific antibodies. And in terms of, preparation, I think I agree with what's been said here. I think, patient and family education is really key here, so that they, understand what the toxicities are. They know when to, come in if needed. In terms of options, in the third line, obviously, there's single agent bispecifics, but there's also combination bispecifics. So this similar to the choices that I mentioned before, Mosun Pola, Glofi GemOx, Epco GemOx. I think all of these are definitely options on the table here. It also depends on the patient's performance status, if they have cytopenias or residual toxicities from the CAR T. Not uncommonly, these patients post-CAR T will come in and, they have significant pancytopenia still, especially if it's early on after CAR T. So there's a lot of factors that you would you want to put in your consideration.
Well, thank you again for your insight, and I would like to move on. I think there are, in the discussion that we will also have when we talk about CARs and bispecs, there are some differences. I think the most important thing is that we don't need any bridging therapy. It's off-the-shelf product for all the bispecs, so we can identify a patient and move straight into therapy, whereas CAR T cells needs preparation, at least 1 to 3 months, and quite often is hindered by insurance coverage questions, which is obviously an administrative question. And I think also important is also our resources are quite stretched with CAR T cells. We have to hospitalize the majority of patients, at least for some days, to really administer the CAR T cells, and particularly also for coping with cytokine release syndrome and ICANS, which usually are of higher incidence when compared to bispecs. So who is not an optimal candidate for CAR T cells, and most likely maybe for bispecs? Patients with poor performance status, ECOG 2 to 3 would be obviously not a candidate for CARs. Patients with significant comorbidities, particularly congestive heart failure, active infections, this is a patient at risk for any really severe infections, and CNS involvement may be an issue here, because some patients or some physicians are of deep concern that the neurotoxicity may be increased by these patients. Autoimmune disease will be another one, and obviously a low reserve of lymphocyte counts. But remember, CAR T cells is chemotherapy plus CAR T cells. You have to give that patient fludarabine and cyclophosphamide, which lead by itself already to quite a lot of aplasia and contradiction for conditioning chemotherapy. What's the evidence of using bispecs in the third line? I think with the 3 approved or recommended, I think the CR rates are in the ballpark between 30 to 40%, with an objective response rate over 50% in large phase 3 cohorts that led to approval in this situation. But then also you also have to look at the real world evidence in these situations. And this is a really good paper that was recently published in Blood by American consortium of 21 centers with 245 patients, demonstrating that both Epcor and glofitamab are equally potent, reaching with a CR rates of roughly around 25%, but with no difference in the activity on PFS. But I think what is quite important, and that's something that we are learning, is that the status of C20, also C19, we'll speak about that later on, is if your CA20 loss or low, these patients seem to be not doing so good with a bispec after a third line situation. Just talking about the dosing, and there are differences between the 3 components, glofitamab here, and you're all aware of that. And the most important thing is that we would recommend that every patient on with receiving glofitamab on day 8, the first time at 2.5 mg, should be hospitalized just to in the situation. This is very different to the Epcor regimen, where you would hospitalize the patient on the step-up dosing on day 15. So that's a very marked difference between the 2 bispecs, which are broadly used in both regions, both in Europe and the United States. And for odronextamab, we have a more elaborate dosing regimen with multiple steps being used for aggressive lymphomas, and a slightly different target dose in follicular lymphoma at about 160 mg in total. So what are the cytokine rates in these bispecific antibodies? I think overall, the majority are really low grade in the 1s and 2s. So there's, I think, no big difference between the components that we're talking about between epcor, glofitamab, and odronextamab. There may be a difference in the grade 3s and 4s that we are seeing, but generally speaking, the cytokine release syndrome rates are lower when compared to CAR T-cell therapy and less frequent. So practical principles for addressing bispecific antibody toxicity. The patient selection. We spoke about that the risk assessment is very important. It is quite clear that someone with high tumor burden, high involvement of the bone marrow, and that is also both for follicular lymphoma and aggressive lymphoma, pretty much the same comorbidities. That's the patient which is at risk. Someone with low tumor burden, IPI-1, for example, with just maybe when he's relapsing with stage 2, would be a low tumor burden patient where you would not expect him to really have severe toxicity. The patient education, and this is not just the patient himself, it is quite important also to reach out to the caregiver, the spouse, that kind of educating her or him about the what is the cytokine release syndrome. The drug administration, then you have to discuss that with the patient, because on the one hand, you have with glofitamab a treatment that is defined with 12 cycles versus epcoritamab or odronextamab until progression. So something that is it has to be discussed with the patients. And I think we don't make any recommendations, but it's a patient's preference in that situation. And then obviously the self-monitoring is very important, and need to check on the vital signs, and that the patient then really knows when to act, when to call, when to present himself within the emergency department. So what are the practical managements of cytokine release syndrome or bispecific antibodies? Consider outpatient evaluation, administer then antipyretics, and continue to monitor the temperature vitals. And this is really important that the caregiver, so the spouse, is educated and really can take up that responsibility in that situation. Someone who is single and has no caregiver, 75 years old. And remember, fever leads to confusion. And so this could really be a problem for a patient. So I rather would recommend to bring in the patient earlier onwards under the circumstances, which hasn't got a good network at home. Then later on, if the patient is grade 2, then that's a period when the patient has to come to the hospital, has to be seen in the ER, has to be evaluated in person, because obviously in these patients, it's not just the cytokine release syndrome that is an issue. It could also be infections, and that needs to be treated adequately in the situation. And we have to make the call if this patient then would receive also tocilizumab in that situation. Anakinra, for example, can be administered, but it's quite rarely in bispecifics that we need that drugs, in my experience. Grade 3, and thankfully that is quite low rate, and that was really in the papers that led to registration, and now in clinical practice, it's very rarely that we have a grade 3. But nevertheless, there has to be capacity for these patients to go to the ICU, to be able to receive vasopressors, to be monitored much more closely in the situation. And grade 4, clearly, that is also someone who has to go to the ICU. But thankfully, with the education that we are delivering and with experience in treating these patients, it's a very rare event. So let's talk about the groups that we identified which are in need. As I said, that patients with post-CAR relapses are patients which are in dire straits. And there is a prospective trial that was looking at a pre-specified cohort of post-CAR cohort in the L1 study, 60 patients. And if a patient has a response in these patients, then the patients have quite a great outlook, reaching a progression-free survival that is meaningful to these patients. And this is particularly for patients which reach a complete remission. We always discuss the situation, what to do then, particularly in a younger patient. Are we going to take them to transplant? But that is something that we maybe take up for the discussion section. So what about using CAR T cells or bispecs in the second line, as they are now moving in? As we heard about that the glofitamab and GemOx regimen is now approved in Europe, but it's also in the NCI guidelines. And I think there are still quite clear thing. I think the CAR T-cell therapies is a curative option for these patients. So please remember, we have very robust data, 5 years follow-up, also in real-world evidence that we still have CAR T-cells being curative in this situation, whereas despite the evidence that is now being emerging, we don't have that long-term follow-up, and it's also just trial data. So preferentially, I still would opt for CAR T-cells in a patient in first relapse to receive CAR T-cells. The bridging options that we have are platinum-based, and it could be involved radiation. It could be polar in patients which have not been receiving polar Vendotin upfront or GDP. And for the patients with non-CAR T-cell candidates, I think the data that we have been seeing with glofitamab GemOx, there's a phase 2 trial demonstrating equal data like with EPCOR and GemOx in this situation. So it's clearly an option that we prefer to give to these patients. And I think what we have been doing in the past, polar plus bendamustine, is now being more and more or less used in those patients. And I think also for patients who are both not candidates for bispecs or for CAR T, so I think Tafalen in the first relapse is a good option, but it's, I think, quite a small proportion of patients. In third line, I think we have a situation which is a little bit more clearer. We have a very clear evidence that bispecifics are the therapy of choice, particularly in patients post-CAR T cells. And for patients who haven't had CAR T cells in the second line, they might qualify in this situation, particularly those with late relapses and could not receive CAR T cells in label. Here, then we can have still an option for cure for these patients. Other options might be long CAR or CD30 positive disease, brentuximab plus lenalidomide and rituximab. So in summary, Thomas, a man aged 80 years with stage 4 with mild heart failure and rapid progressive of first line money chop, is still a patient that we would cut despite his comorbidities. But increasingly, bispecific antibodies can be considered as an alternative option in these patients. And I think over time, we'll see how the real-world data will emerge. And progression after CAR T cells, I think bispecifics have shown that they are the standard of care option in these patients in third line setting with strong evidence supporting their use after CAR T cells.
Good morning, everyone. Thank you for coming. I know it's early morning, so we'll keep it very brief and to the point. And thank you to our sponsors and also PeerView for giving me this opportunity. So I will be talking to you about bispecifics in relapsed refractory follicular lymphoma and how does that and how do we use that in patients with POD24. So here we have a patient, Marcus, is 58 years old with high-risk follicular lymphoma, FLIPI score of 2, has received first-line therapy with bendamustine and rituximab, and relapsed within 14 months of completing the treatment, and then received rituximab and lenalidomide in the second-line setting, and then relapsed within 10 months of completing that treatment. So I would like to ask my panel members here and my colleagues, what is the prognosis of this patient? And would you consider rebiopsying this patient to evaluate the CD20 status?
I think the prognosis is for this patient, particularly in the POD24, quite dismal. He most probably will, every third line, fourth line, he will have shorter responses. And I think also, particularly in a patient who has been exposed to CD20 twice, I think it's always quite good to get a new tumor sample because we have a couple of choices for this patient.
Okay. So, many years ago, these are the patients that we were, considering allogeneic transplant. But that now in the setting of bispecifics and CAR T-cell therapy, I think, we're using less, allogeneic transplant in this setting. And again, these POD24, most of the data with prognosis and the survival and all that mostly have been, after chemoimmunotherapy. But I think for this patient, I probably would consider either a bispecific antibody or a CAR T cell therapy. I would discuss probably both with the patient and see what they, would prefer. Obviously, CAR T cell therapy is a one-time treatment, but then it's also there's a lot of logistical challenges and a lot of time commitment, at least initially. Whereas a bispecific is easier to start, but then it's expected to be on longer therapy in terms of timeline. So I would discuss both options with this patient: a bispecific antibody or CAR T cell therapy.
Okay. Yeah, I agree. I think definitely discussing, because we have both options here, and deciding what is best for this patient. And then rebiopsying, of course, we try to rebiopsy. Looks like the patient was not biopsied since the initial diagnosis. So knowing the CD20 status would be important to decide on the next steps. So now we rebiopsy based on our panel recommendation. The patient still has CD20 positive disease and has a good performance status of 1. And my question to the panel is, would you push for CAR T in this scenario? And if the patient had concerns about spending time away from family, traveling challenges, would you consider a bispecific potentially, and then consider CAR T later?
Well, I would personally push for CAR T cells. There are two arguments. The trial with liso-cel showed very convincing data, plus very low toxicity. So this could be potentially an outpatient situation. And secondly, it's one and done. Whereas with the bispecs, this would be continuous therapy. So I would really try to convince the patient that CAR T cells would be, in this situation, the best choice.
Yeah. So I might have a little bit of a different opinion. So again, follicular lymphoma in general is not curable. Now, the question of CAR T cell therapy, could it cure some patients? I mean, I think that's a very hard question to answer. We've all seen these patients with follicular lymphoma, relapsing 20, 30 years later. So were they cured and now they have a second one? Probably not. It's just an indolent disease that will ultimately relapse. So I would be absolutely comfortable, treating this patient with a bispecific if he, if the patient would prefer that option over CAR T now. And then at a later point, if he relapses post a bispecific, then you could still do the CAR T at that time. Now, if this is a diffuse large B-cell lymphoma, that would be a different situation. I probably would, try to push more for CAR T at this time. Although, who knows, maybe in the future we'll have more data, looking at a bispecific versus CAR T. But for this particular patient, I think it's very reasonable to do the bispecific first and then the CAR T if that's the patient's choice.
Thank you both. I think it's a tough question, and I think it depends on the patient preference, right? So some patients may want to get one-time treatment. The other patients may want to get not come to the CAR T center. So it's something that we usually discuss with the patient, the data that we have, and then make an informed decision along with the patient and the family. I have another case. So now we have an older patient, and this is Evelyn, 82 years old, with relapsed refractory follicular lymphoma. But this patient has a very indolent disease, so has had 3 lines of therapy. The first line was RCVP, had long remission for years. Second, received bendamustine and obinutuzumab, and also had another very long multi-year remission. And more recently received rituximab and Revlimid, and has had noticed recently gradual progression, but not patient is doing well. So the moderate disease burden, preserved ADLs, CD20 is positive. Patient lives in a rural area and lacks consistent partner caregiver support. So in this case, would you consider CAR T or bispecifics? And does the treatment history inform your choice alongside age and the logistical considerations? What has been the efficacy to date with bispecifics in older patients? And how do you address infection risk in older patients?
Well, this is really a difficult case. I think CAR T cells, someone 82 years old plus, is really something that has to be discussed a bit, and it has obviously also a lot of side effects in terms of the ID issues that she may present. The CAR T cells most likely would not be my primary choice, but bispecifics, yes. But then again, she is living on her own and a rural location, so the education on the ID problems that may occur, which are substantial, and particularly in patients older, is a challenge in the situation.
Yeah, I completely agree. I mean, for such a patient, probably they would not get CAR T at, our center if they don't have a caregiver. I think that's a main issue. The other thing is this patient is very different than the patient we discussed previously. So the previous patient was a POD24. Yes, we would try to push, more efficacy with a CAR T option. But this patient is, she gets multiple, years of remissions with each line. Yes, the remissions shorten over time with each line. But this is a much lower risk situation with late relapses. There's a lot of options in this situation. Bispecifics, definitely can be an option. Although if the patient is still concerned about, not having any caregiver at all and whatnot, might sometimes be even challenging for bispecifics. Honestly, this is a patient that, could do well with other things as well, like, maybe tazemetostat even. But I probably would either consider a bispecific or some of the other option, like a tazemetostat. You could even, re-challenge with RCVP if she had a multi-year remission, afterwards. So there's a lot of options. If I'm picking a bispecific, I probably, might consider, mosunetuzumab in this situation.
Sure. Thank you. I agree. So we can look at the data next. What data do we have with bispecifics in relapsed refractory follicular lymphoma? So bispecific antibodies are recommended for treatment of relapsed refractory follicular lymphoma. So this is third line and subsequent lines. And on the NCCN guidelines, both epcoritamab and mosunetuzumab are listed as treatment options. And we also have CAR T cells, as we talked, as options for these patients to consider. And there are other agents listed there that can be used in a relapsed refractory setting. So what are the three bispecifics that we have with our in relapsed refractory? So mosunetuzumab is approved in relapsed refractory follicular lymphoma. There is long-term data published from that study, the pivotal study. And in those patients, 43% of those patients were POD24. So they relapsed within 24 months of receiving the initial treatment. So the fixed duration of mosunetuzumab, like Dr. Samal was saying, this is like 8 to 17 cycles. So in those patients, it would be a good option to consider if patients don't want limited treatment. The CR, in patients who had achieved a CR, the median progression-free survival was 35.9 months, which is long. And the 30-month overall survival was around 92%. And it was highly active in both POD24 and bulky disease. And we have the overall response rate and the CR rate here, which is 74 and 63%. And we can see that median duration of response was around 25.4 months. In POD24 patients, the overall response rate and CR rate was very comparable. So 70% and 58%. The median progression-free survival was around 15.7 months, and 30-month progression-free survival was 41%. So, which is very good outcome in these patients. Epcoritamab is the next bispecific that we have approved in this setting. It does produce deep and durable remission. The pivotal trial was the EPCOR NHL-1 trial, had 128 patients, and they enrolled follicular lymphoma grade 1 to 3A after failure of 2 or more lines of therapy, and had very excellent response rate. So 82% overall response rate, and CR rate was 62.5. 18-month duration of CR, like if you had CR at 18 months, 72% patient maintained that. The estimated 18-month progression-free survival was around 49.4%. High-risk patients, so this trial did enroll high-risk patients. So 61 were like FLIPI of 3 to 5, refractory, 69 were refractory to their last line therapy, and almost 42% were POD 24. The response rate was very similar, and even in POD 24, the response rate was 79 and CR of 64%. And more recently, at the EHA meeting in this year, the pooled data from EPCOR, NHL-1, and the cycle 1 optimization, that's basically they were looking at an added dose to minimize the CRS. And those two, the data from those two trials were pulled together, and they saw the overall response rate was around 84% and CR 65%. And if you had a CR, those patients had a better progression-free survival. And they also looked at the MRD. So among that 135 patients where the MRD data was available, 64 were MRD negative. And as the graph shows you, if you were MRD negative, the progression-free survival was, you had a better chance, the patients had a better chance of remaining in remission. And this is the LM2 data, and this is odronextamab. And this data is in heavily pretreated patient population. 72% were double refractory, 49% were POD 24. Again, very durable remissions once they have that. So overall response rate here was around 80.5, and CR was around 74.92%. It also showed the response was very good in high-risk patient population, including the patients who were refractory to last-line therapy, patients who were refractory to CD20, and also POD 24 patients. The longer-term findings showed durability of the odronextamab. So at a median follow-up around 34 months, there was deep and sustained response seen. The dosing schedule, which we can briefly look at very quickly, there was a de-escalation. So if patients maintain their remission for 9 months or more CR, they could be de-escalated to every 4-week schedule. And even with de-escalation, the CR was maintained in 48 patients. There was no new safety signal seen with the long-term follow-up. And there is an abstract about this in this that will be presented during this conference. So I would encourage you all to stop by on Sunday to look at that abstract. Mosunetuzumab maintains slow. Now, we talked a little bit earlier about older patients. So how do we manage older patients? Are these bispecifics safe to administer in older patients? So this data is looking at the mosunetuzumab in older patients. So 30 patients with age 65 or older, comparing to the patients who are less than 60. And you can see the response rate is very similar and comparable, including the CR rate and the median progression-free survival. So these patients can receive bispecifics in a safe and tolerable way. This is LM2 data looking at odronextamab in patients, in older patients. So again, we have 3 categories here: less than 65, equal to 65 or less than 75, and then older than 75. And as you can see, the response rate are very similar, but in older than 75, slightly less, but it is very comparable. So again, these are drugs are safe to use. We have to sit down with the patient as we talk, look at their age, not only the age, it is a lot of it goes into the performance status and also their comorbidities, what they have, and what are their social support system that they have that who can support them during this treatment. So this slide is a duplicate slide. I just want to point out that the dosing for mosunetuzumab, it is listed here. So cycle 2 onwards, they get 60 milligrams. Then cycle 3 to 8, they are 30 milligrams. And if you're in a CR, you can stop. But if the patients are in a PR, then you can go give up to 17 cycles. And epcoritamab, again, for follicular lymphoma, the day 15 dose is slightly different from the DLBCL dose. So it is like 3 milligram. And then in odronextamab also, the follicular lymphoma dose is slightly different. We have 80 milligram starting with cycle 2 to 4, and then 160 milligram after cycle 5. Understanding the potential infection with bispecific. So that's what we were talking about earlier. It's very important because most of these patients and these trials, when they're done, most of them had received 3 or more prior lines of therapy. They were heavily pre-treated. But these bispecific antibodies do come with a risk of infection. So as you can see, any grade, there are ranging between like 50 to 39%, and grade 3 to 4 infections are around 20%, and grade 5, 3%. So very important to understand, to check these patients, monitor their CMV viral load, prophylax them, which is coming up in my next slide, vaccination. So try to vaccinate before starting the treatment, viral testing, monitoring CMV, hepatitis B, prophylaxing for PJP, for zoster, and also entecavir if they are hepatitis B positive. Monitoring the IVIG and IgG levels. So if patients are hypogammaglobulinemia, we usually say less than 400 and recurrent infections, then those patients you should consider replacing giving them IVIG. So now going back to our patient, Mr. Marcus, who was 58 years old, had a high-risk disease, was POD 24. In this high-risk setting, CAR-T is among the preferred options. However, consider the logistical realities and the patient preference. So have a conversation with the patient and the family. And bispecifics are effective, as I showed you the data. So they are effective. There is data to support the use in this patient. And also in an 82-year-old patient, we do have the data, but this is a challenging case, as we said. In this patient, without the support system, it will be very difficult to give what comorbidities they have. And also the other thing is infections. We want to monitor those infections very closely, and also prophylax them. Next, I would like to invite Dr. Gabala to come and talk about the next bispecifics.
All right. Thank you, Deepa, and thanks for inviting me here to speak today. And we're going to be talking now about some of the future steps and some of the upcoming data. So let's go through this case. So this is Alex is a 59-year-old patient with relapsed diffuse large B-cell lymphoma. So initially presented with a non-germinal DLBCL, IPI score of 3. Had first-line pola R-CHP, was in remission for 14 months, unfortunately relapsed. Went on to receive CAR T-cell therapy, but again, unfortunately, relapsed within 6 months. He is still CD19 positive. Went on to receive glofitamab with GemOx, but again is now progressing. And one thing is his CD20 is now negative. So let me bring up that question for the panel here. How does the antigen persistence or loss influence your next, therapy option in a patient like this who's seen multiple lines of therapy?
Well, I think this is a unfortunately quite common situation that we do see 20, particularly in patients who have been exposed to rituximab and then a bispecific targeting CD20. So if CD19 is preserved, obviously that will be a target. We have in that subset of patients, we can use in-label Lonca as an option, but potentially also a clinical trial might be a good option for this patient.
I agree. It's a difficult situation with multiple lines of therapy and losing now with CD20 negative disease. I think this would be a good patient to consider. If CD19 is still positive, consider loncastuximab. There is also tafa-len or Tuxin. But I think 59, I would really think about a clinical trial. A newer novel agent would be the best option for this patient.
All right. So, is there still a role for T-cell engagers in a clinical trial in this context? And what do you think is the potential for CD19 directed bispecifics in this scenario? Obviously, none of them are still approved, but these are the things that we have right now in clinical trials that I'm going to be discussing.
Well, historically, there's data out there with blinatumomab in that context, demonstrating that a CD19-directed therapy with a bispecific antibody construct leads to high CR rates, but was stopped due to clinical toxicity. But with the emerging data of new CD19-directed TCs, I think we have two compounds. I think they are quite promising in my mind. And the key thing is that the rate of neurotoxicity that led to stop blina development is something that is now being really successfully curbed.
Mm-hmm.
I completely agree. I think a clinical trial and one of the newer agents which you'll be talking about would be a good option to consider in this scenario.
Mm-hmm. All right, great. So that was a good segue to our discussion here. So CD19, bispecifics were actually, the first bispecifics that were, initially developed. So we had blinatumomab, which obviously is approved in ALL. But we have data in lymphoma, and as I was saying, as Dr. Top was mentioning, it has activity, particularly in mantle cell follicular lymphoma, maybe more modest activity in diffuse large B cell. But as you were saying, the issue is the neurotoxicity rates, particularly grade 3 neurotoxicities, were dose limiting, occurred in about 22% of patients. The other thing about blinatumomab is it's a smaller molecule, so its half-life is very short, about 2 hours. So you need a continuous infusion and a pump, and all these logistical things made it very hard to continue developing it. In lymphomas, obviously ALL is a different story because there's a different risk-benefit ratio there. With more limited options, but CD19 bispecific has activity in lymphoma. There's now CD19 bispecifics that are being evaluated in clinical trials in non-Hodgkin's lymphomas as well as other types of hematological malignancies. So the first one I'm going to go through, which has more data, is sorobatamig. So this is a CD19 bispecific antibody. So why do we need, again, a CD19 bispecific? Again, the previously discussed approved bispecifics we've went through, they're all CD20. Some patients might be CD20 negative, and that poses a challenge. So we definitely need more targets to look after. So if you look at Soro, it's designed in such a way that the the CD3 moiety here has a low binding affinity to the CD3 on the T cells, and that theoretically is thought to reduce the incidence of cytokine release syndrome. So it's designed in such a way to have a low affinity to intentionally to CD3 to reduce CRS. On the other hand, CD19 has a high affinity so that to maximize the anti-tumor effect. This is an IgG4, which with a silenced FC portion, so to minimize non-specific T cell activation and also reduce the CRS, also reduce the incidence of killing the T cells themselves. And because this is an antibody, this is not a smaller molecule like blinatumomab, it has a longer half-life, so that gives you a more favorable dosing schema. So right now, Soro is being developed. There is definitely phase 1 data that I'm going to be going through, and there's ongoing phase 2 and phase 3 trials that I'm going to be presenting. So this is it's been through multiple iterations. It went through initially fixed dose escalation, and then a single step-up dosing and a double step-up dosing. But again, this is a work in progress. This is still being developed in the phase 1 and tweaked. But as of right now, the cycle 1 is weekly for the first 3 weeks, day 1, day 8, day 15, with a target dose on day 15. The target dose that we're up to right now is up to 25 milligrams in diffuse large B-cell lymphoma. It's the first cycle is typically done inpatient for monitoring, but again, with the phase 2 study now, it's being looked at as well as outpatient. Patients subsequently would get treated after the first cycle every 2 weeks, and if they go into a CR after 6 cycles, documented twice, they could actually go into a monthly schema. The treatment was done for up to 2 years, so it's also a fixed duration treatment. So this is the diffuse large B cell. This is the follicular lymphoma data set. It is being updated in an oral presentation this Monday. I encourage you to take a look. So these are patients who are heavily pretreated with follicular lymphoma. Some of them have previously seen a bispecific antibody or CAR T cell therapy. The trial mandated that they be CD19 positive. Initially, they mandated that it should be at least 50% positive, but then subsequently was amended. So it's just a positive or negative per the local institution. And it's a very, very active in follicular lymphoma at actually a smaller dose than diffuse large B cells. So at a 7.2 milligram is currently the dose that's being looked at. But if you look here, this is the ASH25 data. So we have 52 patients so far. Really very impressive, response rates. Again, small number of patients, but overall response of 96%, CR rate of 92%. Those who achieved CR, if you look at their MRD, was undetectable in 93% of patients. So again, a very active, agent in follicular lymphoma is definitely going to be very promising in this setting. Moreover, some of the patients who've previously failed a bispecific or CAR T who achieved remission so far, they have not relapsed. So, very, very encouraging. If you look at the diffuse large B-cell lymphoma data set, the doses are different, so they're still being escalated. They're up to 25 milligrams, but you could clearly see here that there is a dose-response relationship with higher doses associated with higher overall response and higher CR rates, now up to 54%. So there's also going to be an updated poster on Monday. Encourage you to take a look at it. Again, for the patients who have had at least the 7.2 milligram dose, those who achieved a CR, 90% of them had undetectable MRD. Responses in this setting are also durable with a 12 months duration of response of 76%. And those who achieved a CR, it's actually at 91%. So again, very promising. And in terms of, if you look at the subset of patients that are, troublemakers, those who have previously failed CAR T cell therapy or a CD20 bispecific, we could clearly see that it's active here. 35% of 35% CRs in post CAR T failures, 45% CRs in post CD20 bispecific antibody failures. In terms of safety, so the CRS rates were all grade 1 and 2. It was 49% in the diffuse large B-cell lymphoma cohort. The numbers are lower for follicular lymphoma. ICANS are seen with the CD19 bispecific, so all grade ICANS were 27%, but grade 3 were lower at 8%. And mostly these are neurotoxicity. They're mostly patients have confusion. It typically lasts for 24 hours. It's usually subsides. Some of these patients may require steroids, but it's definitely something that's much less frequent and much less intense than what you're seeing with CAR T cell therapy, for example. Other side effects, including cytopenias and infections, and those are expected with all bispecific antibodies. So where are we going with this next? So it's being looked at in multiple trials and other diseases as well. So the Soundtrack F1 is looking at this. It's looking into untreated follicular lymphoma, including an arm with rituximab. That's going to be a phase 3 trial. The Soundtrack B is ongoing. That's a phase 2 trial with 2 modules: diffuse large B-cell and follicular lymphoma, after at least 2 prior lines of therapy. Soundtrack E is an early stage phase 1/2, looking at combining it with the BTK inhibitors like acalabrutinib and CLL, also looking at mantle cell lymphoma, as well as combining it with R-CHOP in patients with large B-cell lymphoma. So this is being looked at in multiple settings. The next agent that has some evolving emerging data. It still does not have a name, so it used to be CN201, and now it's MK1045. So this is a CD19 bispecific antibody. It's also IG4 backbone, similar to Soro. The FC domain is also silent, again, to reduce the non-specific T cell activation and CRS. It has a unique CD3 arm. So here they replaced the constant light chain and constant heavy chain domain with a T cell receptor alpha beta. And the idea here is to have a more natural physiologic interaction with the T cell. And, it's thought that theoretically this would lead to less CRS. So it's more optimized CD3 binding side to the T cell. Another thing is with the FC domain silencing, it has no ADCC. And again, that can reduce, the incidence of CRS as well as T cell killing. So there is some, very early data in diffuse large B-cell and follicular lymphoma. There's going to be 2 posters, this ASH, one on Sunday, one on Monday. And we summarize the data here. So if you look at the follicular lymphoma cohort, they have 35 patients. It looks very, promising in this small number of patients. So overall response, 86%, CR rate of 72%. And that's only with a dose of 5 milligrams or higher at this point. What got me interested is indeed the CRS rates were low, 17%, all of them grade 1/2. And I think more striking is there's no ICANS reported in both the follicular lymphomas and the diffuse large B-cell lymphomas. Obviously, they're reporting other neurotoxicities like headaches and whatnot, but there's no immune effector neurological toxicities so far presented. Again, very small number of patients, still in a dose escalation, so we'll have to follow up and see how that pans out. In terms of the diffuse large B-cell lymphoma cohort, so far 39 patients. Overall response 56%, with half of these patients going into CR. But again, similar toxicity rates, 16% CRS, all grade 1/2, and no ICANS so far reported. So let's move on now to, so this is the patient Alex with, um, um, diffuse large B-cell lymphoma, 3 lines of therapy. So yes, there's, other options can be considered in this patient who's seen both CAR T and a bispecific. This patient is a good candidate for a clinical trial. And, based on some of the early evidence, a CD19 bispecific, may offer a chance for, for efficacy. And there's, good so far, good efficacy and safety signals. So I think a CD19 bispecific antibody on a clinical trial is a reasonable choice for this patient. So let's move on to the next case here. So this is a patient with follicular lymphoma, POD24, 65 years old. Stage 3, has mild CKD, so received BR first line, achieved CR, and then 20 months later progressed, so that's a POD24. And currently there's no evidence of transformation, so similar to the patient that Deepa represented, but we did a biopsy now, and there's no transformation. So let me ask the panel here, what would you consider next in this in a second line setting in this POD24 patient? Would you consider chemotherapy, other options, R squared, a bispecific? What would be your choice?
Well, personally, we have data with R squared plus TAFA. I think that would be an option that I would put forward to this patient.
Yeah, so I think this is first line, so we're talking about second line treatment. So I think if a choice is always a clinical trial would be the best option if you have one available. And next steps in CAR T, probably not in the second line. Bispecific, definitely you can consider if that is something the patient wants to do, can get that done. But probably this patient has multiple options. So if the patient has no CKD is one of the things that's going to limit a lot of the clinical trial enrollment, but I would still see if there is any trial available out there.
Yeah. All right. Great. So bispecifics are being looked at now in combinations. So just 2 weeks ago, epcoritamab R squared was actually approved, and as early as second line in relapsed follicular lymphoma. We're going to go over that data. Odronextamab Olympia 5 has some preliminary data going to be presented this ASH. We'll go over it. Mosunetuzumab lenalidomide has an ongoing trial as well. And the bispecifics are also being combined with other chemotherapies or antibody drug conjugates, so either with polatuzumab, Gemox, or Lonca. And this is the phase 3 EPCOR FL1, so this is going to be presented, this ASH, and that's what led to the FDA approval. So it's a randomized trial looking at EPCO R squared versus R squared alone in patients with relapsed refractory follicular lymphoma as early as second line. And, the efficacy was much higher in the EPCO R squared arm. So overall response 89% versus 74%, with a CR rate of 74.5% versus 43%. This trial had a dual endpoint, so overall response and a PFS. And again, with the PFS, the hazard ratio was 0.21, and you could definitely see, the Kaplan-Meier curve here at the bottom. A very stark difference between the EPCO R squared arm and an R squared alone. So based on this data, FDA approved this in November. I think we're all going to be looking forward to the oral abstract on Sunday. Olympia 5 also has the safety run-in data is going to be presented on Monday. So this is with odronextamab plus lenalidomide versus rituximab lenalidomide. This is what's being presented is not obviously the phase 3. This is just the safety run-in in the 32 patients that they had with follicular lymphoma at 2 different dosing schemas. So far in this small number of patients, the overall response was 83 to 89% with a CR rate of around 65%. And no unexpected toxicities, basically, similar, CRS and cytopenias, but nothing yet unexpected. So looking forward to seeing this data as well. Now, in terms of other combinations, so we have the SUNMO trial. This is in diffuse large B-cell lymphoma, combining Mosun plus Pola versus R-GemOx in patients with relapse refractory diffuse large B-cell lymphoma who are ineligible to transplant. So this could be done as early as second line. The addition of polatuzumab, definitely had an impact to Mosun. CR rates, 51% compared to 24% with R-GemOx. Overall response of, 70%. And you could see here, the PFS, there's a, significant difference between both with a hazard ratio of 0.41. So again, the regimen is very active in diffuse large B-cell lymphoma, combining Pola with Mosun. Obviously, it's going to be a challenge moving forward if polatuzumab is going to be used in the first line setting with Pola R-CHP. So I think we need definitely more combinations. The other study, StarGlow, that was previously presented and actually has an updated 3-year update on Monday. So there was there's an overall survival benefit with glofi-GemOx compared to R-GemOx. And now with the 3-year update, we're still seeing, significant differences, obviously, between both groups, with the median PFS with the glofi-GemOx now at 14.4 months versus 3.3 months. A significant difference in overall survival as well. Median OS 25.5 months with glofi-GemOx compared to 12.5 with R-GemOx. Now, this is approved in Europe. In the United States, the FDA saw that there's not a lot of U.S. patients, so they did not grant it approval. However, it is on the NCCN guidelines, and it's being used in clinical practice as early as second line, particularly in patients who are not CAR-T eligible or have no access to CAR-T. Are there other options? Yes. So there is very interesting early data presented this summer in Lugano with glofitamab combined with Lonca. Lonca is an antibody-drug conjugate, CD19 directed. And the data looked very interesting. So, I mean, it's a very small number of patients, about 30 patients with 2 dose levels. Overall response, 93.3% with an 86% CR rates. So I think this is very interesting. Obviously, more data will need to be generated. Something to keep in mind as well is that 50% of these patients actually were second line. So not all of them are, third line plus. 20% of these patients had previously seen CAR-T. So that's going to be another option. So for this patient, that we, Amanda, the first patient that we talked about, with relapsed follicular lymphoma after 1 line of therapy, obviously standard of care options can include R-squared or TAFA R-squared. However, with the recent approvals with, phase 3 data supporting bispecifics like EPCO R-squared, that's also, an option in this setting. And there's more and more clinical trials that are ongoing in this setting. So I think this brings us to the end of our talk here. And I don't know if we have any questions that we could go through maybe.
Well, we do have questions already here. And I maybe just start out with asking straightforward. Do you think any role for Pola after receiving a Pola check in the second, third line?
I mean, if they fail Pola R-CHP, then using it in the second line does not make much sense. Especially if it is a PO, someone who relapsed within 1 year or, very close, I wouldn't use it. Okay, so this is a question just to get everyone going, but a more complicated question. So what is your choice if you have to do bridging prior CAR? Do you use bispecific antibody constructs? And if so, which patient?
Yeah, so I'll talk to you, so my personal, preference with CAR-T, so we see patients coming in that are not, a lot of patients we see are in the second line setting. We're still seeing patients who have not seen polatuzumab. So some of the bridging strategy that we use, obviously, if they have a localized mass, radiation actually can work very nicely in this setting. Polatuzumab rituximab is something I use often. I've used R-GemOx. There is a small subset of patients that I have used bispecifics, but not a huge number. And those are typically, patients that are coming in with rapidly progressive disease that maybe they've seen polatuzumab before, that we want to control their disease. So we've used, Glofi, GemOx in this setting. We've actually tried rapid ramp up single agent glofitamab. But again, it is associated with some higher toxicity, and the efficacy is not the best. One question though is if you're doing it before you collect the T cells, are you going to somehow affect some of the T cells or the exhaustion and whatnot? So that's the part that I'm not really sure about.
Yeah, I mean, that's a question that we struggle with. So I think if it is a patient who's asymptomatic and has low tumor burden who can wait till the CAR T is get here, I think usually you can monitor them closely without giving any bridging. Radiation therapy is an excellent one if it's somebody has pain or a large mass compressing on something, if it is in an area that you can radiate. In terms of like I have used polar Rituxan a lot to bridge patients, but again, those are patients who have not received polatuzumab in the first line. Um, Now we do use Mosin Pola as another option. Gemox, Glofit Gemox is another option. So we have had some clinical trials open with the bispecifics. We have put patients on clinical trial with bispecifics to bridge if the trial allows that. So there are other multiple options, but definitely if someone failed Pola in the first line, I probably would not use that.
So there's another one I think which is interesting. So the question is, how do you approach a patient in third line and ask the question, which of the bispecs to use, definite therapy or treatment to progression? What is your approach?
So I don't have a single approach. I usually let the patient discuss the data with the patient. So patients, when you discuss the data, a lot of them have preferences. Some patients don't want to come for an unlimited time to the cancer center. Some patients, on the other hand, they're very nervous. They don't want to be off treatment because now they have relapse disease after 2 lines of therapy, and most of these assuming that they have relapsed after CAR T. So it depends on the patient. So I've used both, and depending on discussion with the patient. Patients who want limited therapy, I've used the limited option, and someone who wants to go, then epcoritamab is something that we have used in the third line.
Yeah, no, I completely agree. And I think that question is still, kind of unanswered in terms of the best approach. I personally like the fixed duration options. I've also seen a lot of infections, when you go, 2 years plus with some of these, bispecific agents. And I think some of the trials and data now is kind of like trying to tweak and answer that question. What's the best approach? But my personal preference is, because of the severe infections with, indefinite therapy, I think, a time-limited option probably would make more sense.
Oh yeah, I think one question I always struggle with, we've got someone who's 55 years old, has a third-line response with bispecs after CAR T-cell therapy. You taking to transplant, allotransplant. Is that something that you would offer that patient, or is your confidence?
Yeah, I think that's controversial.
That's why I'm asking.
Yeah. So we have considered some allergen, so some of my transplant colleagues have, considered allogeneic, transplant in a very highly selected group of patients. I think we just don't know. That's the bottom line. For I don't think obviously autologous transplant would make sense. These patients are usually chemo refractory, so I think the question here is allogeneic transplant. But I personally am not a huge fan of allo in this setting. But I think if you have a young patient who's motivated, and I think it can be considered.
Great question, tricky one. Full disclosure, I'm an allo. I do allos, so I manage lymphomas and I do my own allos. But and I think the treatment paradigm for DLBCL has been exploring. As you can see, there are so many novel agents coming out. If patients relapse after bispecifics, there are still treatment options, clinical trials out there that are available. Like you can get a CD19 directed treatment that's approved, Lonca, Tafa combinations. So I do consider them. Allo is someone who's young and someone who after bispecific and had gone through CD19, then I would really consider an allo if they don't have any clinical trial options. But otherwise, probably with so many trial options and other things, novel agents, targeted therapies, and there are new CAR T trials targeting other, targets that are available, like CAR Ts that are targeting two different markers on the cell. So I think there are options, but I do reserve that as a last option if someone is young and fit enough to go through it after they've exhausted a lot of the available options.
I have a question here also for the CAR experts. Have you got any data on histiocyte-rich aggressive lymphomas?
Yeah, our outcomes have not been great with the T cell rich, histiocyte rich diffuse large B cell lymphomas, and those are the patients that we typically would try to gear towards a clinical trial. We've actually had very good luck with one of our clinical trials with golcadomide in this setting. But our CAR T experience, I don't know about I'd be interested to hear what your thoughts are. But our at our center, it's not been the best with CAR T.
Yeah, I agree. I think it's one of the most difficult ones to treat once they relapse, even though some of the trials have included them in the CAR T trials. But it is one of the most difficult one. So definitely clinical trial. That may be a patient that I would consider an allo if they are rapidly not responding to things, because we know these are not patients that are going to respond to the available treatments that we have. I don't know how you have managed.
Well, I think it's a very difficult patient population. I completely agree with your approaches. I think we are in all the subsets. It's still a minute population, but nevertheless, we know those patients just are not very responsive in that situation. So going back to another patient population, the frail population, which is not CHOP or mini-CHOP applicable. Do you see bispecs moving into that space? Is there data out there that you find convincing, interesting?
Yes, I think there's very interesting data presented this summer, I think, in Lugano with a Glofipol, Rituxan chemotherapy-free agent regimen. I'm sorry. So I think definitely something intriguing. Not all patients can tolerate chemotherapy. I think those patients may potentially be able to receive a chemotherapy-free option with a bispecific. But again, I think we definitely need more data, because I think the question is it curable? And I think if it is, then we probably should explore it in patients who are younger than 80. But I definitely think that this is going to be a very interesting path going forward.
I agree completely. I think there are multiple trials ongoing looking at this with different bispecifics that we have available. So we need more data, but it is very encouraging to see the bispecifics move in the first line therapy, especially for someone who may not be a candidate for aggressive chemo regimen.
Well, I think on that note, with the sort of emerging data and potentially even replacing chemotherapy in the elderly patients with Bispecs, I think I would like to close the session. And I think we had a good and interactive session. I would like to thank you, my co-speakers, to present the data. And we also would like you to help us record the impact and help to educate our patient community, particularly the sponsor here that has really helped us along. With that, thank you very much, and thanks for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is developed with our educational partner, the HealthTree Foundation for Non-Hodgkin Lymphoma. This activity is supported by independent educational grants from AstraZeneca and Regeneron Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/YAZ860.